which I'll be dealing with is the status of immunotherapy and VEGF inhibitors in renal cell carcinoma. So this is my favorite slide, which I always share whenever I start my talk. Anybody can have any opinion, Sachin? Just
some chemical application from somewhere near Shimla.
Can you see my arrow here? It is moving around this area near the upper part. So this lady was diagnosed by us as a Line RCC metastatic, and after diagnosis she went to Kangra. Kangra is the place where somebody put some acidic solution there as an irritant, and she came back to us in ICU with burns. Fortunately, we were able to salvage her condition. So this is the state of affairs even now. So the basic management of metastatic cell cancer is aimed at maintenance of quality of life, because all these are stage 4 patients. That is the major accent. And of course, prolong the life wherever possible. And in the background, we have to remember in India the drug availability, the regulatory issues, and all these overtones along with the finances. So with this preamble, I go to the guidelines. The NCCN guidelines say that risk stratification is very important. You have favorable and poor and intermediate risk. The one in the favorable risk initially was sunitinib and pazopanib, that is the TKI inhibitors. Now, axitinib and pembrolizumab have come into vogue as the first line for the favorable risk also. In the poor and intermediate risk, you have ipilimumab and nivolumab, which is category 1. And the same axitinib and pembrolizumab is again category 1. And of course, cabozantinib is there, which is not available in our country. So the options for first line, we have tyrosine kinase inhibitors, TKIs. You can have a IO plus IO combination, that is PD-L1 inhibitors plus CTLA4 inhibitors. Then you can have IO plus TKI combination, which I will be coming to subsequently. TKIs we have been using for donkeys of years for treatment of metastatic RCC, and all of us have gone through the body of literature with sunitinib and bevacizumab, interferon, pazopanib. So all these have been there for a long period of time, but when you see the PFS hovering between 8 to 10 months, and so is the OS, which is maximum about 26.4 months. So you have a PFS of about 10 to 11 months and an OS of about 23 to 25 months. And so is the toxicity profile. If you see it in the COMPARZ trial, in which both of them are compared, that is sunitinib and pazopanib, you find that you have a plethora of side effects which all of us are very much conversant with, which can be rash, neutropenia, leukopenia, mucositis, and fatigue, which is very, very important, which is seen in all these patients.
Talwar sir, excuse me, sir, some noise from some instrument, maybe a fan or something from your side.
Now is it okay?
Yeah, better. Fine, sir, fine.
Yeah, sorry for that. Okay, so you have a combination of immuno-oncology drugs and TKIs. The Rationale, of course, is known to all of us. You have the CTLA blockade with ipilimumab. You have the PD-L1 and PD-1 blockade with nivolumab and pembrolizumab and all these drugs. Again, you have the latest combination of VEGF plus PD-L1 or PD-1 inhibition. What the logic behind is that elevated VEGF may inhibit the dendritic cell maturation, causing immunosuppression. And VEGF inhibition may reduce the number of Tregs and tumor-invading myeloid-derived suppressor cells. So anti-VEGF therapy may prime for better effect with anti-PD-1 and anti-PD-L1 therapy. So this is the rationale of combining them. So after that, when you combine IO plus IO or IO TKI, there is a revolution in metastatic RCC treatment. You have a host of drugs, a host of combinations. You have nivolumab plus ipilimumab, you have pembrolizumab plus axitinib, avelumab plus axitinib, atezolizumab plus bevacizumab. But the drugs which have got OS benefit are nivolumab plus ipilimumab and also pembrolizumab plus axitinib. Avelumab has a PFS benefit. Atezolizumab unfortunately could not get an OS benefit after the completion of the trial. So we will be focusing on Nivo-Epi and PEM-Exe for going forward. So if you have the IO-IO combinations, you have the nivolumab plus ipilimumab versus the standard of care, which was sunitinib in RCC. This was the Checkmate 2-1 trial. This was in the first line, and this was a phase 3 study. And we have a 42-month follow-up in this. And as you can see, even at 42 months, the favorable risk patients, there is not much of a difference which is seen between sunitinib and ipi-nivo. But when you come to intermediate and poor risk patients, you find that there is a stark difference when you use TKIs alone, and this is when you use ipilimumab and nivolumab. In fact, here the OS has been about 47 months at 42 months, and as compared to sunitinib, which is about 25 months. So there's almost a doubling which is seen. And as I had alluded to you, the TKIs which were used earlier for all the risk stratifications, the best OS would be about 23 to 25 months. So this is just the double of that. Coming to the IO and the VEGF combinations, the combinations I told you, these two combinations did have a PFS benefit. The ones which had an OS benefit, that was axitinib and pembrolizumab, and this was the KEYNOTE 426 trial. And with that, it got approved by the FDA. The other two trials are pembrolizumab plus lenvatinib versus sunitinib, and nivolumab plus cabazitaxel versus sunitinib. The accrual has been completed, but they have not been yet reported. So this KEYNOTE 426 trial, just to have a deja vu, this is PEM plus Exe. This was pitted against sunitinib. This was a 1:1 randomization in advanced metastatic RCC patients. And the treatment was continued till progression or unacceptable toxicity with the endpoints of overall survival and PFS. And this shows that even in favorable risk, there is a improvement in the OS as well as PFS with a significant overall response rates of 67 versus 50%. So this is about 17% improvement in the ORR. And the CR rates have moved up to 8.8%. Now, this is something which is very, very remarkable in the sense that initially you never had a complete response rate. So CR rates have gone to 8.8%. And the favorable risk had 11% CR rates, whereas the others, they had about 8%. Now, there is a question here. The good risk RCC is always related with the VEGF sensitivity, and this you find that in favorable risk is a high vascular endothelial growth factor sensitivity. And it has been seen that favorable MSKCC risk patients are characterized by the higher angiogenesis gene signature expression. So this could be a probable cause that why that in favorable risk, when ipi-nivo was pitted against sunitinib, the patients fared better with sunitinib because as the risk is lower or as the risk is favorable, there are more angiogenesis gene signatures which are expressed, and they are more adaptable to TKIs or VEGF inhibitors. And that is the reason when you combine pembrolizumab with axitinib, you get an edge. That is, you get the wider difference even in the favorable category vis-a-vis ipilimumab and nivolumab. And again, you see here, when you see across the trials, you have ipilimumab, nivolumab versus sunitinib and PEM-Exe versus sunitinib. You find here that in ipi-nivo, the curves start to separate around the 9 months. Whereas in PEM-Exe, they are opened up from before only. But again, the argument here is that you have a long 42 weeks after which you can assess, whereas in PEM-Exe, you don't have that long-term data. So there is a question mark whether these two curves will come again here, unlike Nivo-Epo, or they'll be going on ahead. So the problem here is if you see Immuno, this thing chart, you find that 9 months the curve separate. Before these 9 months, there is not much benefit between both the two drugs. So here it could be that can this rationale be applied here in PEM-XE where the curves splay up at an earlier date. So could this have an edge over the other, that is IO plus TKI versus IO plus IO. So this is just a comparative assessment. So the question asked is, are we putting RCC patients at unnecessary risk, which we are not offering upfront VEGF inhibition? Do we really need a EP-Nivo combination, or only anti-PD-L1 can work? And can we use only this as first line? These are the questions which have been put forward. So when you use IO-IO combination, there are a lot of pros and cons. There is a mature follow-up, durable response, and unmatched quality of life issues. And there is a potential to stop therapy with higher immune-related adverse events rates. And they, of course, are unpredictable because you don't know where the drug is going to have side effects and where the drug is not going to have side effects. Whereas the TKIs, they have OS benefit. It's unclear when to stop therapy, unlike the IOs. And the follow-up is immature, and the long-term benefit is still unclear. And they also have a lower QI and a high TKI toxicity. So you have PD-L1 as a biomarker, but again, it does not help much as far as RCC is concerned, because here you don't use this when you give drugs like nivolumab. So can a biomarker help us sway our decision when we use these drugs, that is IO-IO versus IO-TKI? There are a host of emerging biomarkers with relevant studies, but again, time will tell because none of them have come out in the forefront. Suffice to say that the neutrophil lymphocyte ratio is very, very important, and so is the tumor mutational burden. Can the morbidity profile sway the decision? Well, morbidity, as you have seen, immuno-oncology drugs, sometimes it may never occur, can be dose dependent. It needs treatment to resolve. When we talk of VEGF TKIs, it is almost guaranteed. It is dose dependent and usually emerges by 3 to 4 weeks and resolves on holding the drug. So there is a totally different profile as far as the adverse events are concerned, and so is the line of treatment. When you see these two trials, that is Checkmate 214 Nivo EP versus PEM-XE, you find that there are more side effects in the TKI group vis-a-vis when you use a combination of EP-Nivo or when you use a combination of PEM-XE. So definitely, as far as the QOL criteria are concerned, the IOLs, they fare better as compared to the TKIs. Patient preference, well, there was a article which was, there was a poster, patient preferences and expectations of systemic therapy C. And the conclusion of this was that patients rank efficacy as the most important outcome when considering treatment options. Toxicity, time and cost are not significant priorities for patients upfront. Of course, this is from the Caucasian data, because in India, finance is a big problem. And further data is warranted to see the impact of communicating treatment options, potential discontinuation of therapy, and resulting expectations. If you have patient preferences, you have physician preference also. Physicians also, given a choice, would like to give drugs which are oral like TKI, and some of them have preferences regarding IO drugs also, because most of the side effects, as we know, are because of ipilimumab. So physicians prefer combination of nivolumab with the TKIs or nivolumab with the TKIs, the studies which I just told you which are coming. So some, or rather most of the physicians might be uncomfortable in using PD-L1 plus CTLA-4 because most of the side effects are because of CTLA-4 drugs. Although, as we know, that the dose of ipilimumab is very, very less, 1 milligram, when it is used in combination in RCC, unlike the higher dose which is used in melanoma. Long-term data prospective studies are dreadfully needed because at this point of time, we are just working on PFS or the OS at 30 months or 40 months. And longer data, at least around 5 years, is warranted before we come to conclusion. First-line treatment, what is the right choice? Multiple good systemic therapy options are available. Good risk patients and those with favorable have a survival of many years with or without therapy. And there was an article in which treatment was withheld in certain patients who had a good risk. So if you have patients with intermediate or poor risk IMDC, no significant autoimmune diseases, because that's a contraindication for IO drugs. And there are some potential VEGF contraindications like comorbidities, hypertension, or intolerance. And there is a need to avoid chronic VEGF adverse events. Then you consider a combination of Immuno-Oncology drugs plus CTLA-4. On the contrary, patients with the IMDC favorable or intermediate risk, in which there is only one point which is making the risk stratification upgrade to intermediate risk, or in patients with intermediate or poor risk disease who need a rapid response, or a need to avoid the immune-related adverse events associated with the dual IO therapy, or if the patients have a significant autoimmune diseases. These are the patients who can be considered for a combination of IO plus TKI, that is pembrolizumab plus axitinib. Because at this point of time, we have two champions. One is CTLA-4 plus IO and IO plus TKI, which are giving the overall survival benefits. The other drugs are definitely in the pipeline in phase 2 or 3 studies, and the results are yet to come about. And these are the phase 3 trials which are on the radar screen, that is lenvatinib plus pembrolizumab versus sunitinib versus lenvatinib and everolimus. And there's another one with cabozantinib with nivolumab versus sunitinib. All these are phase 3 trials, and the first 3 trials are the first line. And even there are trials on locally advanced and adjuvant settings in which pembrolizumab versus placebo is being tried, and nivolumab plus ipilimumab versus placebo are being tried in T2, T3, and N1 lesions. And they are also phase 3 trials. The approval has been completed. They are large trials. So it remains to be seen that when the results come in, they'll be very, very interesting. So I think I'll stop here, and I thank you for your patience.